venetoclax, maybe it leaves them with a little less room, and you're probably not going to use them with an HMA after venetoclax HMA failure. So I kind of feel like they're falling by the wayside a little bit.
Yeah. So it's a bit of a paradox, right, on when to use.
Right.
Because, there's promising, but once you kind of had venetoclax, you don't, and HMAs, then that's your resilient population. Once they respond, and adding an IDH on may be too late, but it's also unjustified to add an expensive drug on too early, right?
Correct. Yeah.
Okay. Very helpful. So what I want to show you next, Doctor, is a concept profile. It's really just a few sentences because, again, as I mentioned, the drug's in early development. And the goal here is, actually, before I do that, sorry, I got a little ahead of myself. We'll get to that in just a moment. What I wanted to ask you, and you've touched on some of this, is, if we jumped on the phone 5 years from now, 5 to 10 years from now, where do we think would be different, right? So structurally about some of those treatment flows we talked about, or, are there some buckets or slots, if we've got HMA in there today, it's the same patient population, but now we're going to look at Ven plus HMA or margetuximab or CD47 plus HMA. What do you think is going to be the big differences 5 years from now, structurally or types of therapies that are being used? Or even the thing we talked about at the beginning, the typing of patients and risk factors.
Yes, I hope some of the drugs we just talked about in that last slide will be approved. And I think the days of using HMA alone for intermediate high risk MDS will be gone. I don't think we're going to be using HMAs alone unless a patient can't tolerate anything else.
Right.
So that's one thing. I think there will be more triplets, like CD47 plus HMA plus venetoclax, for example. I'm people really want to see a cellular therapy like a CAR T, TCR, some kind of cell therapy approach that will work for myeloid malignancies. There's a lot of ongoing work on that right now. NK cell therapy, CAR T cell, something like that. One other kind of thing that people are really interested in is we're able to detect, in theory, MDS even at the early stages of diagnosis, even pre-MDS.
Mm-hmm.
And so there are thoughts around, could we be treating that? So basically like prevention of MDS, prevention of AML. That's something that's like, it's far away, but it's something that people are discussing now. If you could sequence the blood of everyone at age 40, you could, in theory, identify people that, are going to get MDS before they get it, and maybe you could intervene in some way. Those things are out there. Those are the kind of, I think, the biggest things.
Okay. And then I skipped over number 2. You were talking about the triplet therapies. What was the one that you felt was most likely? Was that the IDH one, or was that something else?
Oh no, Ven HMA 47.
HMA 47. Okay. So those look like the big lists.
Yeah.
So I didn't see some of the other AML sort of usual suspects in there, right? So I didn't see FLT3. I didn't see. We talked about Aprea and the TP53 already a little bit. I didn't see. Gosh, what else is some of the biologics? Although you alluded to it a little bit in the bigger bucket of immunotherapy, the biospecifics and such, right? Are any of those you think either amenable or anywhere near prime time for MDS, or is that a totally different ball of wax?
Yeah, a lot of those things either aren't panning out so well in AML right now as it is, or not as common in MDS, like FLT3 mutations, just not that common in MDS. So even if they're effective, it's only going to be 5% of patients that could benefit, for example.
And as I'm actually unfamiliar with the FLT3 inhibitor data in MDS. I've been following it. Is it not panning out? Not terribly convincing? Just not being studied?
Yeah, I'm not sure that it's rare, so I don't. who wants to do a clinical trial